welcome, and thanks for joining our discussion about AL amyloidosis. My name is Camille Pope, and I am a Now Included community member. I'm also the Chief Medical Lead for Now Included and Acclinate. As a reminder, our Now Included platform allows you to share your story and gain health information, specifically around health issues concerning communities of color. And so while this call is recorded for those who might be missing it, we do encourage you to share the link with family and friends who might be available now and want to join live and learn about AL amyloidosis along with you. So as I mentioned, today's topic is AL amyloidosis. It's a rare disease that can have a disproportionate impact on those of us in the Black community and also other communities of color. And our guest is Kathi Luis from the Amyloidosis Foundation. And so Kathi will be sharing a few slides about AL amyloidosis with us, but she'll also be talking about health inequities, health disparities, and how everyday people like us can share our concerns about rare diseases like AL amyloidosis and health inequality with our local and state policymakers to help make change in those areas. Now, while Kathi has a few slides that she wants to share with us, we still want this to be interactive and conversational. So I encourage you to please answer the few poll questions that we have throughout the presentation. And also feel free to type your questions in the chat and we'll try to address them as we go along. We also will have an opportunity to have a Q&A session at the end of the discussion. And with that, I would love to turn it over to Kathi. Kathi, can you share a bit about yourself?
Absolutely. I will actually share my slides.
Okay, great.
Okay. Well, I want to thank everybody for joining and thank Now Included and Acclinate for having me here. My name is Kathi Luis. I'm the Special Projects Director at the Amyloidosis Foundation. And that includes many different jobs. With nonprofits, we're often short-staffed. And so you do many jobs. I call myself the Jill of all trades. I do have my degree in allied health. And as you can see on the screen, I'm a member of a lot of different communities and organizations, including different advocacy and for the patient advocacy and legislative advocacy roles with pharmaceutical companies. I traveled to Washington, D.C. every year to participate in Rare Disease Week on Capitol Hill, and there I attend caucus briefings and legislative conferences and meet with my legislators. I also advocate for rare disease with the NIH, FDA, and Centers for Medicaid and Medicare Services. So I will go to the next slide here. I do want to differentiate the different types of amyloidosis, and there are 5 most common in the US. HATTR is a hereditary form of amyloidosis caused by a gene mutation. Wild type is related to aging. AA is, it occurs as kind of like a reaction to another illness, such as chronic inflammatory disease or a chronic infection. ALECT2 is what we call acquired, and it may be digenic. And by that, they mean that it can be the result of a combination of 2 different disorders that combine in a genetic sequence. So it could be genetic caused by 2 separate things combining. And then AL is light chain. That's what we're going to be talking about today. And that's caused by a bone marrow disorder. And we'll talk more about that on the next slide. But I also want to note that typing of the different amyloid proteins is really important because they're all treated differently. Each type is treated differently. So before any type of treatment needs to be started, they need to rule out whether it's hereditary or, whether it's AL. So I will go to the next slide here. Okay. A little short synopsis about amyloidosis. AL is caused by proteins that misfold. And when these proteins misfold, they're deposited in organs, tissues, and nerves. And as they build up in that organ, they tend to affect the function of the organ, or they can even shut it down. Each amyloidosis patient is different and has the deposits accumulate in different places. But another thing, it often affects more than one organ, and AL does not affect the brain. I know a lot of people, think of amyloid proteins, and there's amyloid proteins that are, prevalent with Alzheimer's and dementia, and amyloidosis affects every part of the body except the brain. And so I will go on to.
Hold on, wait, Kathi, I have a question for you on that previous slide. Can we go back?
Absolutely.
Thanks. So I would love to, focus on the right part of that slide where we talk about the symptoms. We see the picture of the person there, and it's like the symptoms include fatigue, shortness of breath, diarrhea, constipation, pain. Like these seem like symptoms that could be anything, right? So, is it common for AL amyloidosis to be misdiagnosed by physicians and for them and patients to think it's actually something else because these are kind of like these broad symptoms?
It is very easily not diagnosed as amyloidosis. Okay. These can mimic several different disorders. And without the proper awareness out there are still a lot of physicians that have never heard of amyloidosis before.
Wow. Okay.
It is definitely not something that they automatically think of, which we are working real hard to change.
Got it. So it sounds like there's got to be education for patients, but also education for physicians too, who might not see this like every day in their practice.
Right, which is one of the things that the foundation I work for does. It's one of the things the Amyloidosis Foundation does. So I will get to that probably near the end. And we do have a question. What specific blood tests can determine the diagnosis? That is a question that we get a lot. And there is no single one blood test that can determine whether you have amyloidosis or not. What physicians that are well-versed with amyloidosis usually do is they use several different blood tests as a reference guide. And if they end up suspecting it due to your symptoms, blood work, protein in the urine, if they end up suspecting it, then they will do a biopsy. And a biopsy is the only way for a definitive diagnosis. And it could be a fat pad biopsy. It's taken from the abdomen, and the little fat there we have in the abdomen, and it uses a hollow needle and it pulls out some tissue and cells, and then those go under a microscope, and they're dyed with Congo red dye. And if there's like a green outer ridge, or they call it birefringe, then it's positive for amyloidosis. So that can be done, the fat pad biopsy, but that's not always perfectly accurate because sometimes it doesn't accumulate there in the fat pad. Sometimes it's just in your heart or just in, your ligament or tissue. So they need to kind of really look at those blood tests as a reference to see where they think the amyloid proteins are accumulating.
Got it. Thank you. That was a really great question. Because it's like after you experience the symptoms, then what? Yeah, when you're thinking, well, what do I have? Is it AL amyloidosis or is it something else? And so Kathy's explanation of how you have to, there are additional blood tests, not just one specific, but a blood test that can be used as a guide and then biopsy is really helpful. We actually also have a poll question, again, just out of curiosity to highlight how some of these symptoms can mimic other diseases. Out of curiosity as a community, have you ever, any of you ever experienced any of these symptoms? Okay. And again, not saying that you have AL amyloidosis, but like we're getting everybody saying like, yes, 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 yes. You can see the answers popping up on the screen. Let's see, give it another second or two for people to respond. Okay. And showing the results. So 83% of you have had some type of symptom that is a potential symptom of AL amyloidosis. Again, doesn't mean that you have AL amyloidosis. It just really reiterates the fact that these symptoms are very broad. And so you do have to do that additional, questioning and discussion with your doctor and the additional blood tests to rule out things and maybe even a biopsy to determine is it actually AL amyloidosis, because the symptoms look like so many other diseases that could be out there. All right. Thanks, you guys, for your poll participation. That excites me. We have another poll question later on, so let's let Kathy keep going so we can get to it.
Okay.
Yeah.
All right. Now I'm going to talk about health inequity. The racial and ethnic minorities are underrepresented in publications on systemic light chain amyloidosis, as I'm sure they are in many other publications. Healthcare disparity typically refers to differences between groups, whether it's health insurance coverage, access to care, and quality of care. The terms health inequality and inequity are also used to refer to different disparities, which result in conditions that unfairly either advantage or disadvantage anyone else, placing people of color at a greater risk for poor health outcomes. In this study on the screen from Boston University, racial ethnic minorities comprise a really small portion of patients, drawing attention to the barriers of healthcare access. The more severe diagnosis with AL was detected amongst non-Hispanic Blacks and Hispanics. And as you can see in the table where I put the little red box around, these populations are sorely underrepresented. These findings show the need for earlier detection in underrepresented communities before something like, say, cardiac disease, which is prevalent with amyloidosis. So something like cardiac disease becomes too advanced for somebody to qualify for the proper treatment. Tackling these economic barriers and expanding resources in easy to understand wording and funding care coordination programs can help bridge that gap to treatment. And it's also worth mentioning that race and ethnicity did not impact the outcomes after diagnosis. So this is just, getting the underrepresented communities in to see the physician. So greater awareness is needed, along with innovative approaches to make these services and technologies available so that there can be the earlier detection and identification of AL. Also, a systemic lack of detection can be at the root of this inequity. If somebody has structural heart changes, kidney disease, neuropathy, like Camille was saying, that it can be misdiagnosed, and they may think, oh, you just have congestive heart failure, when somebody can have congestive heart failure as part of their amyloidosis. So that's something that we often see in late diagnosis. So things to consider: disparities in access to testing and specialized treatment centers often reflect socioeconomic obstacles, which vary by race and ethnicity. When evaluating cardiac amyloidosis in persons of African ancestry, hereditary ATTR needs to be excluded before any diagnosis of AL can be established. That's what I was talking about just before on the last slide. So despite an evolving therapeutic landscape for AL amyloidosis, in the study, racial and ethnic minorities were less likely to receive treatment, with Hispanics. Yeah, I know, crazy. With Hispanics in particular, having a 30% lower likelihood compared to non-Hispanic whites. So, and similar patterns have been reported in multiple myeloma, which occurs in about 15 to 17% of AL amyloidosis patients, which also contributes to a higher mortality risk. I'm going to go on to the next slide here.
Well, I think we can keep it on the slide, Kathi, but I do have a question for our community members based on like what you just shared. That's really like eye-opening information, you know, and I'm curious, eye-opening information highlighting how those of us who are Black and brown and historically underrepresented in research, that also can lead to being underrepresented in just the care, the paradigm of care and the ability to access the treatments that we need or even get the right diagnosis. And so I'm curious, community members, and feel free to put it in the Q&A. I was told that the chat was disabled. My bad. I didn't realize the chat was disabled. You can put it in the Q&A. Have you ever experienced that? Not with, you know, necessarily AL amyloidosis, but any ailment that you may have had and felt like I'm receiving maybe lesser care, or have less access, or I feel disadvantaged, you know, based on my background, my race, ethnicity, where I come from, some type of bias, or maybe, you know, just like a challenge that I'm experiencing. Is that something that you've ever experienced? Feel free to, you know, say yes, no in the Q&A, and share. We'd love to see your responses.
And I would be surprised if the people on the call or anyone really didn't feel some kind of bias when they go in. Any you know, like me, I'm Hispanic, any Hispanic or person of African ancestry. Oh, they're coming in.
They're coming in. So Ms. Wani says, I have lupus, and yes, I felt this way. My rheumatologist was not responsive or communicative. I now have a more supportive care team. Thank you for sharing, Wani. That's important. Like, you can always change your doctor. You know, like if you're feeling like you're not getting the answers and the responses and the care that you need, seeking a second, third opinion and finding that more supportive care team is a must. So
that's awesome. A follow-up question?
Yeah.
I'd like to know how you came about getting that more supportive care team.
Let me see, Miss Juanice. I think I can.
That was my niece.
I'm gonna see if I can give her an opportunity to chat here. If you'd like to, Miss Juanice, to answer that question live. If not, just say, you know, no, and you can put it back in the Q&A.
Hi.
Hi.
Thank you. I know, because sometimes I could just continue typing up a storm. So thank you for allowing me to speak. I once I got diagnosed, and there was a whole thing surrounding that. I just, I sort of felt like every time I came to my rheumatologist with a question, it would be kind of, tossed to the side, or he would dismiss it as, well, just take the medication. Just take for lupus, it was Plaquenil. Just take the Plaquenil and let's just see, let me know in a few months how things are going and how your symptoms are. And that was not, as someone who just got how I felt was devastating news that I had lupus, that was not the type of care that I wanted and needed. And that continued for a while until I finally took control and became my own advocate, and with the community, the family that I have now, and the new community. And I said, I need to move on. I need to move on to another rheumatologist. And so I did that. And now I love my care team, and they're giving me exactly what I want and what I need. I mean, some diseases are very complex. So, it helps to have support.
Well, good for you. I'm really glad that you were able to find that.
Yeah, thank you, Ms. Juanice, for sharing.
And we do have another one and another two, if you want to take that, Camille.
Sure. So another response, someone said, yes, my ailment was challenged in that I was given minimal medication. So sounds like an instance where the physician didn't believe what the patient was saying, and said, and it led to ineffective or treatment treatment that was less than what should have been prescribed. And then, so thank you, whoever that was, anonymous attendee. And then we have another anonymous response. Yes, I was diagnosed with AL after several months of swollen legs. Wow. I went to another hospital and found a doctor who had experience with amyloidosis. And there is where I received great care. So again, thank you for sharing. Sounds like, again, someone had symptoms and felt like, okay, this doctor that I'm going to now doesn't have experience in this. I need to figure out what's really wrong with me and seek another opinion. And that led to the appropriate care. And so with any disease, in that instance, it was amyloidosis. In Ms. Juanice's case, it was lupus. You have that right. If you feel like I'm not getting the answers that I need, and we talk about people being subject matter experts, Kathi. And one of the things I always say is people are subject matter experts of their own experiences and their own bodies and illnesses and what they are feeling.
And you have to advocate for yourself. I always, tell my kids, you have to do this for yourself because nobody else is going to do it for you. Yep.
Awesome. Well, thank you all for participating in that little chat interaction. Ms. Belinda said she's learned how to be her self-advocate. So again, just piggybacking off of Kathi said. So thank you, Ms. Belinda. And we'll let Kathi go on to her next slide. So let's keep going.
Well, here we go. I was having some technical difficulties. Okay. Identifying and getting rid of some of these barriers to treatment is really important. Beyond the disparities in coverage, people of color and lower income individuals also receive poor quality of care. And this is what we were talking about, with that medication, it gave a lesser medication. So this slide right here is from Kaiser Family Foundation and in a survey called The Undefeated. And this shows survey data that finds that Black adults are more likely than white adults to report certain negative healthcare experiences, such as a provider not believing them, like we just spoke about, and refusing them a test, treatment, pain medication, that they thought they really needed. If you take a look at that slide, you can see that there's many different factors within and beyond the healthcare system that drive this inequality in health and healthcare. Research shows that health outcomes are driven by multiple factors, including genetics, health behaviors, social and environmental factors, and access to healthcare. So while there's currently no general consensus in the behaviors and social and economic factors, often referred to as social determinants of health, there are primary drivers of health outcomes. And this slide kind of shows the different forms that can determine whether they can get proper health care or not. And another thing to add is that racism negatively affects mental and physical health, both directly and by creating these inequities across the social determinants of health.
Thanks, Kathi. I was just going to highlight in the chat, I already responded to his comment, but okay. Dominic said, thank you for talking about these different factors and social determinants is what we call them of health that can impact healthcare and the ability for someone to receive the appropriate healthcare and to have good health. Because there are all these different components, and not everyone is always thinking about how they fit together and how they influence one another. And it's not just about, individual lifestyle factors, and you can tell somebody, oh, change this and you'll be healthy. Like, no, there are educational gaps, food issues, the racism, all kinds of things can play a role in transportation. And, again, if we're taking it back to a rare disease like AL amyloidosis, it's no different. It's no different. It might even, these things could maybe play a role even more so because it's a disease that is rare and isn't seen as commonly or treated as commonly as some more common illnesses.
I agree.
Ms. Belinda commented and said, we can add age to this list. You're right. You're right.
Absolutely. Absolutely. I agree.
Mm-hmm. Yep. People thinking that because you're maybe more well-seasoned, that you don't know what you're talking about, or attributing any symptom that you have to you being older or well-seasoned and not really looking for the cause.
I'm going to use that to describe my age now. I'm well seasoned. All right, I will go ahead and if there's no more questions here, I'll go ahead and move on to the next slide.
Okay.
And it's not going. Okay. All right, now I'm going to describe a little bit about the legislative work that I do, or how you can make a difference more so. Reaching out to your legislators can definitely make a difference. At the Amyloidosis Foundation, I am currently working on 2 state-level bills and 21 federal initiatives. We're working on bills for things like access to medications, telehealth, lowering out-of-pocket costs for patients, among many, many other bills. And there's a lot of different strategies for promoting policy change. You could tag your legislator on social media promoting a bill. You could write a letter, meet them in person at their office, etc. I find that the most effective way is to meet them personally and tell my story. Yeah, they love hearing your story. And it's your story or a story of a loved one. So you already know it. You live it. So that's something that's easy to tell. And usually the meetings, they last around 15 minutes. But legislators do love hearing from their constituents. or in other words, their voters. Constituents have power. Legislators are the most responsive to the registered voters in their own districts. What I do is I Google my legislator before the meeting to see if I have anything in common with them. You know, that could be family, social, business, political ties. Mentioning them may help you make a stronger connection. And their own website usually shows where they went to school, etc. So you could, you know, if you're a fan of their football program, or, you know, just try to find something in common. And how it works is I usually go in, I introduce myself, I'm really clear about what I want, and I call that my ask. You need to be clear about what you want that legislator to do. And then tell your story, reiterate what you want them to do, thank them for their time, and ask for a business card and a picture. And the reason why I always ask them for a picture is to put it on social media. When I do this, I follow up by tagging them with the picture and a little explanation, like I met with Congressman Bayer today to talk about telehealth, which would improve the outcome for people of color. Also, I use their business card. It'll have their email on it. So I use their business card to email them and write them a thank you for meeting with you, and emphasize, you know, what you spoke about, where you stand on that issue. I also think the squeaky wheel gets the grease, meaning reach out multiple times, be on their radar. You may sometimes meet with a legislative aide or a staffer, and that's okay. It's actually good. They're the ones who do all the research on the bill, and they speak to the legislator about it. So they will convey your story. And some tips I have for dealing with the legislators, like I said, build that relationship, you know, find something that you have in common, be polite, be respectful of their time, because oftentimes they have several meetings a day and they are just running from one to another, and that's not even when they're in session. Be nonpartisan in your asks. It's easy to do once you start doing it, but go in as a constituent, not as a Democrat, a Republican, or an independent. Try not to break down during your story. Sometimes that is a hard task, but tell the facts as they are. You want to be sure to be able to convey those feelings that you have in another way. Let's see what else. It's okay to disagree, and you don't have to argue, you know, you don't have to agree with everything about your legislator, but don't argue with them, because you will need his or her support in the future on future issues that you want to present. And if they ask you a question and you don't know the answer, don't bluff. Say, you know, I'm not sure about that answer, but I will get that to you by, and then give them a certain time. On the slide here, I have a graphic about how a bill becomes a law. And you don't need to know this like the back of your hand. You really don't even need to know it at all. But it's there just so that you have a little bit of an understanding about the process. Most bills can take a year to several years to be passed. And also on this slide, I have put my email. If you're unsure of a policy to talk about, reach out to me. I can help you find one that speaks to you. And if you have questions after the webinar also, you know, there's my email. So don't hesitate to reach out.
Thank you, Kathi. That's awesome. I loved how you highlighted sharing your story, because we know Now Included is the platform where we say, like, this is for people to share their stories. But there's also importance in sharing stories with decision makers who can bring awareness, more awareness and change around the particular disease that you might be I don't want to say you might be thriving with, right? Because we thrive. Or, if you're seeing, if you've experienced, as many of you said that you had as community members, some kind of healthcare inequity related to your disease, rare disease, AL amyloidosis, something else, like, there are decision makers out here who we can talk to, who might not even be aware of this, and could be moved by your story to pass legislation that changes the game. And so it's important for us to, like, think about it in that way too. And I don't think we necessarily do. I know I don't always think to do this on health related or community issues. So this is really cool, Kathi. And I saw we had a question. It went away, but
oh, well, I answered that question, but there's
okay.
Rose wanted to mention that I am part of the Now Included community, so you can also reach out to me that way.
Okay, great. And so I do have one more poll question before Kathi tells us a little bit more about how she supports patients and caregivers as part of the Amyloidosis Foundation. And it is around reaching out to, like, your congressperson. I'm just curious, Kathi and I are curious, community members, have you ever reached out to a congressperson or policymaker about a health issue or community issue that is concerning to you? Have you ever thought to do this? A lot of no's coming through.
I'm excited to see this one.
I know, another few seconds to see, because we could have we should have done a pre and a post test, right? Ask this question before your presentation, Kathi, and then you talk about it. And then, like, a month later, we ask folks, and all the answers go from no to, like, yes, I reach out to my legislator all the time. And am I sharing my screen? I don't know if you can see it.
I cannot.
Okay. Well, I don't know if I can share the results on the screen, but I can let you all know that of the answers. So 31%, 36% just went up of you have said yes, you have actually reached out to your congressperson or policymaker about a health issue or community issue that concerns you. And then 9 of you, so 64%, said no. So maybe this is a call to action, and hearing how Kathi does her work and how she can support you, especially from an amyloidosis perspective. If you're thinking about addressing policy around amyloidosis or healthcare disparities, it's a call to action for you to maybe change that answer to yes if you responded no.
Absolutely. And, like it says right there on the side, Congress works for all of us.
There we go.
There, now I see it.
Right, there are the results real quick. Okay. All right. So then before we wrap up, Kathi, would love for you to share with us a bit more about how the Amyloidosis Foundation supports patients and caregivers who have been patients who are diagnosed with amyloidosis, caregivers who are interested in supporting their family members or friends who've been diagnosed. What are some of the other things besides the legislative work that Amyloidosis Foundation does, and what resources are available? Awesome.
Sure. We provide support in many different ways. Research, we have given over $2 million to research through grants by funding junior research scientists whose research targets the challenges in the field of amyloidosis. Since the prognosis for late diagnosed amyloidosis patients is rather poor, the foundation has now decided to also support a 1-year advanced hematology amyloidosis fellowship. We have travel grants, and providing travel grants to physicians and researchers. We provide these to those who have completed their medical doctorate or fellowship within the past 10 years. These grants enable participation in the biannual International Amyloidosis Symposium, which is in a different country every year. And we also do grand rounds. This is probably one of my favorite programs because we sponsor an expert in amyloidosis to go and speak to other doctors and medical staff regarding diagnostic tools, clinical protocols, treatment therapies, just the latest and most current therapies. And this also helps raise awareness. And our speakers are among the most knowledgeable specialists in the US, and they're involved in amyloidosis research and patient care. So we'll arrange for that speaker and cover their travel expenses and honoraria. So that is, like I said, one of my favorite things, because I think that more physicians need to know about amyloidosis. It needs much more awareness. Now, other than that, we have our website, which is listed there with a lot of timely information. We're actually in the process of redoing our website. It should be live I'm hoping within the next couple of weeks. And it's just going to be more user-friendly. We have a caregiver and patient binder. And what this does is it's got a lot of different sections. It can be downloadable, or we can actually physically send it to a person. It allows the patient to keep everything in one place. So you can keep your appointments, your questions in between appointments, your testing results. It's got a lot of different sections, charts, and so forth. And so that's something that we came up with about 2 years ago. And they've been kind of flying off the shelves. That's a great resource. We also have webinars that are recorded and posted to our website if people miss the live webinar. We have a list of treatment centers and physicians that specialize in amyloidosis. There's a list of support groups, financial resources. We have pamphlets that have updated information, because just since 2018, there have been 4 drug approvals. So it's an ever-changing paradigm, or ever-changing landscape. So we keep those updated. We have quarterly newsletters, which are also, if you don't sign up for it or aren't able to view it, we have it later on our website where you can view it. And our social media is listed there. We post to each of these sites at least once a day. And again, it's with timely information. If there's a grant opportunity that opens up with financial assistance available to patients, then that gets posted right away. We get notifications right away. So we post about it. Unfortunately, the financial resources, they go fast. So there's a lot of people out there that need help, and they do go fast. So, keeping up with us on Facebook, especially, but our Facebook Facebook for us is kind of like where our patients talk to us, and where we post a lot of timely information. Twitter is mostly used for our medical community, and Instagram, we like to post just very happy, inspirational, motivational, and sometimes funny things, just to know, you're not alone. We're here for you. We get you. We understand what you're going through. And so that's about it. Camille.
Thank you, Kathi. No, that was great. appreciate you going through all of the different resources. Some of the things that stood out to me were the binder. That's super important because like a lot of times when you're in a doctor's appointment and getting a lot of information, even if you have somebody like with you, like a partner or a family member or a caregiver, it's just like, how do you capture everything that's being said to you? Mm-hmm. And everything is being handed out to you. So having a binder that you can like, you do it electronic, or like you said, you mail them to people that you can carry around with you and you can flip through and you've got your notes and the date and what Dr. So-and-so said, like that is awesome. I think that is an awesome resource. In addition to all the other ones you talked about, Kathi. And also, I love how you kind of highlighted how you're on social media. I mean, it's 2022, everybody's on social media, but like each one of your social media platforms has like a different vibe. So like the Facebook is, okay, people having conversations. Twitter is more for the physicians. I know in my past life, I learned that, very intimately that a lot of your physicians are on Twitter. That's where they get a lot of health information from reputable sources, the reputable sources that are there. Some things changing, but back in the day, like Twitter was like that's a place where physicians got a lot of information, and then how Instagram is more like the inspiration to help people kind of just get those quick memes to keep them going through tough days. Yeah. So I love that.
Oh, thank you.
You're welcome. So we have in the chat, we just have Rose, our now included community manager, posted some reminders for those of you on the call that you can join our now included AL amyloidosis community. So that's also a resource for you. You can join our community, share your stories, hear from other community members who are who care about AL amyloidosis. And also Kathi and I are also both community members, so you might hear something from us too. And then our broader now included community where we have other areas of focus beyond AL amyloidosis. You can join that as well. So are there any additional questions before we wrap up from those of you on the line? Please feel free to post them in the Q&A and we will take some time to answer them if there are any. All right. Oh. We have one from Denise. Hey, Denise. What kind of doctors specialize in this area? I may have missed that. So Kathi, can you share a little bit about who might be treating this disease?
Absolutely. You didn't miss it, Denise. Usually people start with a hematologist, although it really depends on your symptoms. AL can be cardiac amyloidosis as well. So if you're having cardiac manifestations, arrhythmia, heart failure, any of those, you might go to a cardiologist first. But usually with AL, we always tell people to start with a hematologist. And a lot of times those people are in cancer centers, and it doesn't mean that you have a cancer. Amyloidosis is not a cancer. So it is just treated at cancer centers a lot of times because hematology and oncology go hand in hand. So a lot of the hematologists work at cancer centers. I would start with hematology. We do have a list on our website. And then if you give us a call personally, we will tell you the physician's name and the line to his office, his or her. We've got people all over the world, a list of people all over the world. And although there isn't a physician that treats amyloidosis in every state, it's pretty close. In places like on the East Coast in Boston, New York, they have a bunch of them, Florida, California, Texas, so there's almost a physician in every state.
Thanks, Kathi. And then we also have a comment from Miss Belinda, who says, I started with a nephrologist because of my leg swelling. The symptoms can be so various. It is difficult where to start with a specialist. So that's a great point. That goes back to the symptoms that might mimic like other things. Leg swelling could be a lot of other health challenges. So, it may be you start with the primary care physician, and then based on whatever your symptoms are, you end up at a nephrologist or a cardiologist or a hematologist. But then the hematologists, it sounds like, are the primary treaters once you've been diagnosed. Okay.
Yeah. Well, most primary care physicians haven't even heard of this. And that's where the problem lies. The leg swelling, edema, can also be from heart failure. So that's, I'm really happy that, you found somebody that knows, where to start. But I always tell people that you wouldn't go to a fish market to buy a steak. So, you need a specialist in the field of amyloidosis to be treated and diagnosed for amyloidosis. If that makes sense. I hope that makes sense.
Yep. Nope. That makes a lot of sense. And Miss Belinda responded. She said, absolutely. Her primary care physician thought it was heart failure, but that was not it. And a person with an ailment must be persistent. So Miss Belinda, you're so right. It's all about finding, who's going to help you find the right answers and be able to make the correct diagnosis and take it from there.
Yeah. Wonderful. And again, we bring up advocate for yourself. You have to be persistent. You have to advocate for yourself. I usually tell our patients, though, if they're thinking they have amyloidosis, don't Google it. A lot of different rare diseases, when you Google them, there's a lot of misinformation and outdated information because they're ever changing. So we usually recommend the hematologist to start your journey.
Great. Thank you, Kathi. Well, seeing no more questions, and since we're nearing the top of the hour, wait, there might be another question. I saw something pop up. Ms. Juanise,
I agree.
Just reiterating, don't go down a rabbit hole with Googling symptoms. Don't do it. We got you, Ms. Juanise. Don't do it.
You'll think you have everything in the world.
Exactly. That's funny. Thank you for calling that out. Well, we are nearing the end of our time. We thank you all for joining. We thank you, Kathi. This has been awesome. Just a wealth of information. We appreciate your time and your effort for being a member of our Now Included community and sharing your expertise. And we thank all of our community members who joined today. Remember that this is recorded, so if you want to share it, Rose will, I don't know, she'll post a recording in the community, but we will let y'all know how you can get the recording and you can share it. I think it's going to be on our YouTube page. Yeah. Yep. It'll be on our Now Included YouTube page, and she'll also put it in the community. So thank you all so much and appreciate you. Have a great Thursday.
Thank you, everyone. Bye.